Assalamu alaikum, dear colleagues. Thank you, Mr. Chairman, for the generous introduction. And I'd like to take the opportunity also to thank the organizers for their kind invitation and for accommodating the change in the schedule. So my task is really to talk about diabetic emergencies during Ramadan. And as you all know, the diabetic emergencies are managed in pretty much the same way during and outside of Ramadan. So what I'm going to try and do is really talk about some of the strategies that we can use in order to avoid our patients ending up with any sort of diabetic emergencies. I don't have any relevant disclosures, and this is the outline. What I will try and do is first highlight what are the potential risks that are associated with Ramadan fasting, particularly in people with diabetes. And then we'll discuss how to stratify the patient's risk, because according to that, we can then say whether the patient can fast safely or not. And then we'll look at those strategies that would be used in order to mitigate those risks. So it goes without saying that Ramadan is a special time in the life of a Muslim. It is an opportunity for us to reconnect with our Lord. It leads to improvements in both our physical and mental well-being as well. From a medical perspective, we know that if done correctly and not fasting and sort of feasting, we can actually see a significant amount of weight loss after Ramadan. And this may lead to an improvement in the hemoglobin A1C, in lipid profile, and even in blood pressure levels. And as a result of the weight loss and an improvement in glycemic control, in those patients who have fatty liver, now currently referred to as metabolic associated liver disease, can also see improvements in their liver function tests and the amount of steatosis. So it's got these medical benefits that are really so important. Just 1 month can lead to all these significant medical outcomes. But we also need to be aware of the challenges and risks during Ramadan. Now, the first thing is Ramadan comes as a great disruptor of our daily routines. And that in itself can create a lot of problems. Then you have the sort of grazing or snacking that happens during the permitted hours. That can lead to a lot of disturbances in glycemic balance. The meal compositions, already now if you go to our supermarkets, you will find that they've already stocked up Vimtos and all the sweets and all sorts of dates have already been stocked up onto the shelves, because that's what happens. All of a sudden, because you think you fasted for 12, 14 hours, you're entitled to indulge in a high carbohydrate, high fat foods. And this can, of course, cause a negative impact on our glycemic control. Then, of course, you all know about the sleeping patterns. Yeah, some people just change it to, you sleep during the day while you're fasting, and then they're up all night during the permitted hours. That in itself, of course, is going to cause a change in the circadian rhythm. And in people with diabetes, this can grossly affect their glycemic control as well. The other thing that happens is that if patients are not adequately educated and informed about their disease, what they're going to do is probably miss appointments or reduce their medication because they think they're fasting, and that can also then negatively impact their glycemic control. Now, just to illustrate this phenomena, these are the CGM profile of, I don't know if the pointers are working. Yeah, so this is the CGM profile of healthy individuals. And as you can see, during Ramadan is your red bars, and before Ramadan, the blue, they're almost superimposable. There's not much of a glycemic fluctuation in healthy individuals. Compare that with what happens in individuals who have diabetes. And you can see that before Ramadan, you had a nice blue curve, and all of a sudden you have this dip that may occur just before the iftar meal, and then you have a sudden spike that is occurring just after Ramadan. And so this is what we are worried about. We don't want them to have these dips, and we don't want to have this spike after they break their fast as well. So the most fearful risks for any patient with diabetes who wants to embark on Ramadan fasting is, of course, hypo and hyperglycemia. But we also need to take in mind that dehydration, particularly in hot climate, that doesn't happen everywhere, or if the fasting hours are greater than 16 hours, that might lead to dehydration and increase the risk for thrombosis as well. So we need to look at what are the sort of strategies that we can help our patients with in order to strike this balance. Now, the APDR is one of the landmark diabetes in Ramadan trials. It was published some time ago in 2004, but it was the first of the trials that really informed us about the rates of glycemic crisis in Ramadan. And here I show you the risk for developing severe hypoglycemia was 7.5-fold in the overall population, would include patients with both type 1 and type 2 diabetes. And then for ketoacidosis and other hypoglycemic crisis, there was a 5-fold increase. Of course, the risk for developing either of these complications increases as you increase the number of days that you fasted. So if you look at those who had fasted for more than 15 days, their risk for getting hypoglycemia was 6.7-fold. And then for hyperglycemia, it was about 4.4-fold. Within the APDR, we think that these hypoglycemic emergencies happened because the insulin dose either remained unchanged, because that's what they found in 64% of the population, or the oral medication dose remained unchanged in about 75%. That would then have accounted for the hyperglycemia that we saw in this study. Fast forward to 2015, we had the CREED study, which more or less showed the same thing, that those patients who fasted longer had a higher risk for developing hypoglycemic events. And they recorded about 8.8% of the patients, particularly with type 2 diabetes. And the other important observation that came out of this study was the fact that if somebody had history of hypoglycemia before Ramadan, that was already associated with an increased risk of hypoglycemia during Ramadan as well. So what are the factors that may be associated with this increased risk of hypoglycemia? Definitely your elderly patients who are frail, anybody that's on dialysis or has CKD stage 4 to 5, those who have hypoglycemia unawareness, anybody who has poor glycemic control, so hemoglobin A1C is in the range of 9 to 10, also increase the risk for hypoglycemia. Tight glycemic control as well, the use of insulin or insulin secretagogues, and an acute illness will also increase the risk of hypoglycemia. Now, with regards to the oral hypoglycemic agents, the ones that are notoriously known to increase the risk, of course, the sulfonylureas. But I would like to point out that the second generation sulfonylureas have less risk for hypoglycemia. As you can see, gliclazide and then to some extent glimepiride have a much lower risk of hypoglycemia. Fortunately, we don't have glibenclamide and we're not using glibenclamide, but certain parts of the world do that. And it would be wise to change your patient to a second generation sulfonylurea in order to avoid the risk of hypoglycemia. Now let's look at hyperglycemia. And what the APDR had shown was in fact that both patients with type 1 and type 2 diabetes were at risk. It was a 5-fold increased risk in patients with type 2 diabetes and a 3-fold increased risk for patients with type 1 diabetes. However, we conducted a study in 2016 that looked at the risk of diabetic ketoacidosis before, during, and after Ramadan. And reassuringly, we didn't find any difference in the DKA rate before, during, or after Ramadan. And we think this is because by this time we are using better insulins and some form of education had already started appearing within a focused Ramadan education for our patients. APDR was published in 2004, and the patients in that study were mainly in the older insulins. And we think this might have accounted for that difference. Now, more recently, this data has been verified as well by a study that was conducted by Professor Bashaya in Abu Dhabi, and they looked at the 10-year retrospective data, and it also confirmed that there was no risk of DKA during Ramadan. More recently in Qatar, they also did a study that looked at the incidence of diabetic ketoacidosis, and it didn't differ much in Ramadan compared to the other months. So how do we reduce the risk then? First and foremost is to make sure that every patient who has diabetes has the opportunity to have a pre-Ramadan risk assessment. And this should happen 6 to 8 weeks before Ramadan. So all of you in your clinics should have already been talking to your patients weeks ahead about what they need to be doing with their medications and so on. The pre-Ramadan assessment is to look at the type of diabetes, what medications they're on, look at the individual circumstances, what has changed. Is their renal, have they developed renal impairment? Did they have any sort of macrovascular disease? Then the other thing is to look at SMBG. So there may be patients who don't normally check their blood sugars or do it very infrequently. But if the patient wants to fast during Ramadan, they need to agree that SMBG has to be part of their plan. The other thing is that a patient also needs to agree that they will break their fast if their blood glucose levels are in the hypoglycemic range, so anything less than 70 or anything above 300 milligrams per deciliter. So we have clear guidelines from the International Diabetes Federation together with the Diabetes and Ramadan Alliance, which looks at 5 key components for the Ramadan-focused education. Risk quantification, which I will briefly touch upon. Blood glucose monitoring has to be emphasized. Diet and fluid recommendations individualized to the patient. How much exercise can the patient engage themselves with? And then we'll talk about in more depth about the changes in the medications that need to be done so that the patient is not at risk of developing either hypo or hyperglycemia. So this is what the risk scoring system looks like. There are 14 elements, but we've removed what I've blocked out over here is pregnancy, because pregnancy in of itself is a high risk state, and therefore we're not including it anymore in the risk quantification. So as you can see, we look at the type of diabetes, the duration of the diabetes, the presence of hypoglycemia, the level of glycemic control, and you get a risk score beside it, the type of treatment that the patient is on, whether they're able to engage in self-monitoring. We look at any acute complications, and then other comorbidities. And then we also look at renal complications. If the patient is frail, what about physical labor? And then their previous Ramadan experience and the number of hours. Once you've done all that, and this is available on the DAR website for free, you can download it on your mobile phones. And you can do this very quickly in the clinic. In some centers, it's actually already incorporated in the electronic record systems. So then you have a very nice traffic light system whereby you can look at, low risk is in green, moderate risk is in the amber, and those who score anything above 6 are in the high risk and therefore should be advised not to fast. The idea of having it in a traffic light system is also helpful because then you can share this with your patient and actually tell them you're in the red zone and you should not be fasting. When do they need to test? We would like them to test at least at 7 points during the day. So they need to start off at midday. You then need to have a test just before the evening meal. You need to test at night as well. And in the morning, pre-suhoor as well, the patients should be able to fast. And at any point, if they've got a low blood sugar reading of less than 70 milligrams or anything above 300, they should break their fast. They should break their fast as well if they're feeling unwell, irrespective of the blood glucose levels. So now let me focus on the medication management. And of course, we have the oral hypoglycemic agents. We have insulin and insulin, the different types of insulin, both long, short-acting, and the mixed insulins as well. Let me start with the most commonly prescribed agent that most of your patients will be on during Ramadan. So metformin is quite safe. It's not associated with severe hypoglycemia. And patients may need to make some changes in the timing of the administration. So if a patient is on a once daily dosing, they don't need to make any dose adjustment. They just take their medication at the time of iftar. If they're on a twice daily dosing, then they just take it at the time of iftar and suhoor. If it's 3 times, so say somebody's on 500 milligrams 3 times a day, they can combine their afternoon, the lunch dose with iftar and take the second dose at the time of suhoor. For those that are on the prolonged release metformin, the XR formulation, they don't require to have any dose modification, and they can take that at the time of iftar. The sulfonylureas are the second most prescribed agents, and these are the ones that we need to be careful about because of their inherent risk for hypoglycemia. If an individual is taking a once daily dosing, then they need to take that at iftar. If the patient is going into Ramadan with an HbA1c that's less than 6%, then you would need to advise them to at least reduce their sulfonylurea dose by about 20%. So if they were on gliclazide, full dose, you tell them, please take 90 or 60 milligrams and then observe and see what happens during the course of the month. Twice daily dosing, all they need to do is have the dose taken at iftar and half the dose at the time of suhoor. And as I've said earlier, because of the risk with the older generation drugs such as glibenclamide, you want to avoid that. And therefore, you can choose either a gliclazide-based molecule or glimepiride instead. The same goes for the short-acting insulin secretagogues. So these are things like repaglinide. They also have a much lower risk for hypoglycemia because they're shorter acting. And so in those patients that are very tightly controlled, you might want to reduce the dose by about 10 to 20%. What about the DPP-4 inhibitors? These are very friendly for Ramadan. They don't require any dose adjustment, and they can be taken either at suhoor or at iftar, depending on the patient's preference. The TZDs also have a low risk of hypoglycemia and don't require to have any dose adjustment and can be taken at the time of iftar as well. What about acarbose? Because of the side effects, the GI side effects, we're not using acarbose as much, but if your patient is on it, then they don't need to have any sort of dose adjustment. The risk for hypoglycemia for this agent is very low. The SGLT2 inhibitors, we've now gathered enough evidence, or quite a lot of evidence, that they are safe to be used during Ramadan as well. Importantly, they need to be initiated at least 2 weeks or a month prior to Ramadan. They should be taken with the iftar meal. We recommend that the patients are adequately hydrated during the non-fasting hours. The only time you would use them, or rather have to use them with caution, is if the patient is going through an acute illness. Then of course you would need to stop. And if the patient has an acute illness, they shouldn't be fasting anyway. Patients that are on a high dose of diuretics, you might need to have to adjust the dose of the diuretics. But no dose adjustment is actually required for any SGLT2 inhibitor during Ramadan. Now, the new kid on the block is oral semaglutide. And for most of you, many of your patients might be going into Ramadan for the first time on this oral agent because it's just become sort of available. Importantly, a patient needs to be on it at least 6 to 8 weeks prior to Ramadan. So it's not a drug that you want to initiate a week or during Ramadan. And also to avoid any up titration or escalation of the dose during Ramadan. That should be done at least 2 to 4 weeks before that. Patients should be going into Ramadan on the effective dose, which is 7 or 14 milligrams. 3 milligrams is only the initiation dose. The recommendations are for the patients to take it at the time of iftar. So they break their fast with water and their tablet. They then need to wait for half an hour because that's the prescription recommendation. They can go and do their prayers, and then after that they can have their iftar meal. The reason for that is, of course, semaglutide is an oral peptide which is linked to the snack, which is the an absorber enhancer. And if you don't take it on an empty stomach, what happens is that the enhancer can easily be dissolved, and then the availability of the drug is next to zero. So it's as good as taking nothing at all. What about the GLP-1 receptor agonists? These are also very Ramadan friendly. Patients do not need to make any adjustments to their dose, but it's not an agent that you want to also initiate just before Ramadan or increase the dose during Ramadan. They need to be on their tolerable dose at least 2 to 4 weeks before the start of Ramadan. Insulin therapy is usually the tricky one, and we have a number of observational studies that have looked at both long-acting, short-acting, the analogs, the older insulins, and the mixed insulins as well. So for the long-acting insulins or the basal insulins, either NPH, Detamir, which we're not using so much, but Glargine and Degludec, if the patient is on a once daily regimen, then you need to reduce the dose by about 15 to 30%. And we encourage the patients to take that dose at the time of iftar. If they're on a twice daily dose, then they will take the usual dose at the time of iftar, but then reduce the second dose by 50%, and that can be taken at the time of suhoor. Short-acting insulin, obviously, again, will be taken at the time of iftar, and we have a little algorithm for the patients as well. Depending on what their blood glucose levels are, they can either reduce the insulin dose or increase the insulin dose by 2 to 4 units.
Dr. Khadija, time is up.
Oh, right. Okay, so that's my last slide. The mixed insulin is more or less the same. And then importantly is also to make sure that the patient has a post-Ramadan assessment. And to summarize, therefore, a pre-Ramadan assessment is extremely important to evaluate the patient's risk. Those individuals that are on multiple anti-diabetic therapies are the ones who are at a greater risk for hypoglycemia, and so dose reductions need to be made. A post-Ramadan follow-up is equally important, and with the correct sort of advice and support from us, most patients with diabetes should be able to fast safely during Ramadan. And thank you all for your attention.